Also, thank you for being here at such an early hour in Saturday. And yes, I'm proud that rheumatology is linked to everything. So we have cardio-rheumatology, hemato-rheumatology, everything. We are a little bit selfish that we always put rheumatology at the end. So with my sister, who is an oncologist, Eva, we actually wrote a list of possibilities of links to rheumatic disease and cancer. Many of them will be discussed later by our colleagues in the next 3 talks. So what if you have a rheumatic disease? You can have secondary malignancies, you can have soluble tumor-associated antigens, you can have a possible increase by drugs, which will be presented later. And also there's the question whether you can do physical therapy and balneotherapy or not. And secondly, when you have a cancer patients, there is a possibility of paraneoplastic rheumatic syndromes. Also, after chemotherapy and immune checkpoint inhibitors, you may develop some immunity, which will be presented also after me. And there is also the osteoporosis caused by hormone deprivation therapy in cancer, and certainly you can have malignancies of the musculoskeletal pain. So if you want to plot these 8 pillars, and this is 8 pillars of oncorheumatology, somebody might find a 9th or a 10th or an 11th, but these are the major topics I will talk about very shortly. So this is an introductory review, and after that the 3 more talks will actually go into details after all this. So basically the arthritis or autoimmune disease will be linked to the cancer, and there are also some treatment modalities included on anti-rheumatic treatment modalities, and also anti-cancer treatment modalities, and I will go into detail. So first, let's just go for the first 4 ones. What if a rheumatic patient has cancer, or what if a rheumatic patient has some cancer-associated features? And number 1 would be there is an increase of secondary cancer in rheumatic diseases. We all know that. It's especially in B-cell diseases like rheumatoid arthritis, lupus, Sjögren's syndrome, or scleroderma. There is an increase of lymphoma due to the constant stimulation of B-cells, but also some internal organs can have cancer. And you know that in rheumatoid arthritis, both rheumatoid inflammation as well as smoking can cause lung cancer. So the most common solid cancer in rheumatoid arthritis is lung cancer, while in systemic sclerosis, of course, inflammation involves the skin, esophagus, or the lung, and therefore you can have these lymphomas. There are several mechanisms behind that, and this is plotted nicely by this Nature Review paper, that actually when you have activation of a level of immune cells, these immune cells produce cytokines, produce oncogenes, produce JAK-STAT, and all these others which can actually induce the development of cancer. So in every patient where you have a long-term disease, especially if it's not controlled enough, you have to look for malignancies. And you know that when we didn't have so many of the biologics at the very early ages, and we started to have these biologics in 2006 in the Swedish registry, it seemed that inflammatory activity is actually associated with the risk of lymphoma. If you have high inflammatory activity, actually it was 70 times higher risk for lymphoma, and I think there will be a talk after me how it changed with the use of biologics and others. Now, in the Comora registry, which included Romania as well, and 17 other countries, they were actually testing lots of RA patients, almost 1,000 patients, and they were looking at, the comorbidities. And what's in this red quadrangle, you can see that actually these were the percentage of patients with a certain cancer. So it could be 2 to 3%, 4% in rheumatoid arthritis in many countries. So, 2 out of your 100 rheumatoid arthritis patients definitely will have cancer. And therefore, you have to check them, you have to screen them, and we are not doing so well to that. So when we actually looked at our patients, 516 patients, we found 13 cases of cancer in 2008. This is an old story, and 6 of them had lung cancer. So basically, it's in Hungarian, I'm sorry for that, but these had long-term disease. They were a little bit undertreated. They received a lot of immunosuppressive drugs, And so we found that, for instance, lung cancer in the bottom of the slide, you can find that the standard incidence ratio was 10.9. So we found that it's about 10 times higher risk for instance, lung cancer in rheumatoid arthritis. We also published a few cases of malignancies in systemic sclerosis. At that time, we had a little bit more than 200 systemic sclerosis patients, and we found 11 cases of cancer, and we also published some cases of lymphoma, but again, it was lymphoma, esophageal cancer, and mostly lung cancer, which were the most prevalent among these patients. So the bottom line of this first point is that if you have a long-term inflammation and a long-term disease, you have to always be aware that a patient can have cancer. The second one, which is very interesting, is that what if you look for tumor-associated antigens because you want to find cancer? Is it a good idea or not? And it seems that the calcioembryonic antigen or all these other tumor-associated antigens seem to be adhesion molecules or neutrophils as well. So they are associated with inflammation. So when I worked in Chicago in 95 and 96, we actually tested calcioembryonic antigen in the rheumatoid synovium, and it turns out that it's everywhere in the synovium. So it seems that CEA is not only associated with colon cancer, but it's also associated with rheumatoid arthritis. So we think that it's not a good idea to do this. And yes, and after that, with Eva, which was her PhD thesis, we tested rheumatoid arthritis, scleroderma, and lupus patients, and it seemed that, yes, in the circulating tumor-associated antigens were elevated in rheumatoid arthritis compared to control patients, and it was also associated with rheumatoid factor. So if you test an RA patient and it's high, let's say calcioembryonic antigen or CA125 or CA199, that is actually coming from the inflammation. So therefore, it's not recommended to screen calcioembryonic antigen in these patients unless this is like very, very high. If it's very, very high, that might lead to cancer. And we also, did this study in lupus and scleroderma, and we found that almost all tumor-associated antigen levels are elevated in lupus and scleroderma. And for instance, in systemic sclerosis, calcioembryonic antigen or CA1999 and all these others were actually also associated with renal involvement or polyarthritis. So if you have cases of scleroderma, you might have an elevated antigen level. What about the third part? And I'm not going to go into too many details because this will be the topic of one of the following talks, but I have to mention that EULAR actually just finished the guidelines, how to use biologics in cancer patients. Actually, the manuscript is already corrected, and it's submitted to Annals of the Rheumatic Diseases, and the data were presented at this EULAR in Milano, so you could have seen it. Therefore, I'm allowed to show you some of the data. But in general, we think that the old drugs like azathioprine, cyclosporine, cyclophosphamide, they might increase cancer risk. So remember when we were, a long time ago, it was already recommended that Imuran or cyclophosphamide shouldn't be given to RA patients for longer than 6 months because of the carcinogenicity. Now it changed, but it's still an existing problem. And as you know, very first time we gave biologics in patients in a refractory phase. So long-term RA, untreated RA, and then you gave infliximab, adalimumab, or etanercept, and therefore in the Swedish registry in 2006 there was clearly an elevated risk for lymphomas, for instance, in many studies, in rheumatoid arthritis treated by anti-TNF. So we were very much afraid of anti-TNF. But later on, when you looked at the rabbit registry, then the American registry, and finally against the Swedish registry in 2017, for instance, everything disappeared. So now in 2023, we think that it's almost none of the biologics and the JAK inhibitors would, in general, increase the risk of malignancies. Of course, we can have some details, later on. And what is even more important, that there is not an increase in cancer relapses. So if you had a cancer in in the past, you can initiate anti-TNF. In Hungary, for instance, for a long time, it was in the local recommendations that 5 years after cancer, you cannot give any biologics. And that's awful, because the patient is already almost treated, you know, and they have high, you know, inflammatory arthritis, they have pain and everything, and doctors were waiting for 5 years, giving steroids and everything, and no, I think it has to be changed. And so if the oncologist said that the patient is in remission, you can immediately start an anti-TNF or whatever you want. I'm not going to go into so much detail with the oral surveillance, but of course it was also a signal that JAK inhibitors might increase malignancy risk. But of course, we know that this was a very selected population. These were patients with a 10-year disease duration, highly undertreated, and they had a cardiovascular risk. And we also know that cardiovascular risk might drive malignancy risk. So basically, the oral surveillance is contrast to the standard population. If you take the standard population, the JAK inhibitors have no increased risk. So when the EULAR points of consider was developed by Eden Sebag and Jacques-Éric Gottenberg, and I was also part of the group, and as I said, it will be published very soon. We thought that in general, targeted therapies could be, you know, considered in patients with past cancer, but you have to be a little bit afraid or a little bit more cautious when you start JAK inhibitors. And as you also know, there are signals that abatacept may also increase melanoma a little bit. So therefore, this is the points to consider, but the whole you know, list of points will be published soon, and then you will have a guidance what to do in your patient, but in general, you shouldn't be afraid of that. And this is also the same with physical therapy. We in Romania and in Hungary and in Eastern Europe, of course, we love physical therapy, balneotherapy. This doesn't make such an interest in Western Europe, but here in this part of Europe, we have to be careful because all these patients go there. And remember, in the old times, if you had cancer, you couldn't do anything. No balneo, no physical, no electro, not even exercise. We were all afraid. And these are, of course, the modalities of physical therapy and physiotherapy. And so it turns out in meta-analysis that physical therapy and balneotherapy is not only good for the rheumatic symptoms, it's also good for the cancer patient. Cancer patients also have depression, they have pain and everything. So in this very nice meta-analysis, it seems that the physical function is improved by physical therapy in cancer patients, even if they don't have any rheumatic symptoms. And it's also good, I'm not showing that data, that they also have a very good influence on their mental issues. So there is no problem. They will not be depressed and everything. So I think our approach should change, and we should limit, of course, what we can do and what we can't do. So actually, this is a part of musculoskeletal rehabilitation. We should use physical therapy and balneotherapy even after cancer, but there has to be an individualized assessment of risk and benefit. If you have a breast cancer, you are not applying electrotherapy on the chest, but you can still treat the knees, that's for sure. And of course, we know that TENS is probably the least problematic because it's a very superficial electrotherapy. You are not supposed to give ultrasound or deeper electrotherapy and balneotherapy. Of course, when you immerse the whole body in hot water, that is quite questionable, but in some cases, of course, you can still use it. So definitely the oncologist and the rheumatologist and the balneologist and the rehab persons have to work together, and in every single case, you have to assess individually whether balneotherapy, I mean, you can easily go to Sovata Lake because Sovata Lake is not so hot, and you can immerse yourself and swim. I myself love Sovata Lake, so I go there. Now, the second part would be, of course, the other way around. What if you have cancer, and what if you have to think about rheumatic diseases? And number one would be the paraneoplasias. And sometimes it's not so easy. Is it an autoimmune disease with a secondary cancer, like dermatomyositis, or is it a paraneoplasia? And of course, sometimes it's difficult. But paraneoplasias usually occur before you have an autoimmune disease. So you already know that the patient had lung cancer or lymphoma, and then they will develop something. But sometimes it's not so easy. Like last month, we had a patient with dermatomyositis, and with the dermatomyositis, we investigated, and the patient had lung cancer. We have no idea whether the cancer initiated the dermatomyositis or the patient had dermatomyositis and developed cancer. So sometimes, but it's all the same actually at the beginning, at the end. So paraneoplasias is usually developed by any substances produced by the cancer. They produce a lot of growth factors. If you produce growth factors, that can lead to fibroblast activation and scleroderma, or scleroderma-like symptoms, or bone diseases. On the right-hand side, you know the very, very famous link between lung cancer and, of course, the clubbing fingers and the hypertrophic osteoarthropathy of the fingers, which is quite important. So actually, there is a link between the cancer. The cancer is producing some substances even very far from where the cancer is. So if you have an autoimmune disease, which is not just classically looking, or it's not responding to the general therapy, you always have to think about an underlying cancer. For instance, in myositis, if the CK is not going down by giving steroids or cyclosporine, you have to look for the cancer. And we had some cases like this in the past, and of course you can have connective tissue disease like paraneoplasias, you can have RA like paraneoplasia, different arthritis like polychondritis, you can have a lot of skin and muscle diseases, you can have gout, you can have even vasculitis or bone diseases. These are just some of our cases. Two of them on the top is coming from Miskolc by Dr. Tamási. One was a 49-year-old female who had carcinoma polyarthritis. The hands very much look like rheumatoid arthritis, and it turned out to be a breast cancer. Then another male patient had just gout. There was no issue, but it was very difficult to treat that gout. And when he looked for it, actually this patient had two cancers, one rectal cancer and one renal cancer. And the one in the bottom is actually our case of a palmar fasciitis polyarthritis syndrome, which is very similar to scleroderma. So we first thought this is a scleroderma patient. Look at the hands with Raynaud's and skin thickening and everything, but then we made this chest x-ray and it revealed a lung cancer behind that. So if you have a not normal but a quite unusual presentation of an autoimmune syndrome, or it's not responding to the general therapy like biologics or anything, you have to look for cancer. On the other hand, in most cases, if you then remove the cancer, then the autoimmune disease will a little bit go back. Not always. Sometimes it stays because it's already triggered. Now, the next point would be, of course, rheumatic disease after oncotherapy, and we are going to have from Daniela talk about that. But not only the checkpoint inhibitors, but also cytotoxic drugs can cause some kind of musculoskeletal syndromes, including cisplatin, aromatase inhibitors, and even interferons like arthralgia, myalgia. But it's usually very easy to treat, like you can give NSAIDs or sometimes corticosteroids, and then it goes away. Certainly, you have to treat the cancer by any means. And the immune checkpoints I just go through. And of course, the first studies came when they knocked out the PD-1, of course, checkpoint in mice, and it caused arthritis. And of course, these are the features, but that will be presented. And up till now, there are not too many cases of Raynaud's syndrome. And we had a patient who was a male, born in 1967 with planocellular cancer, also HPV positive of the pharynx, and the patient got 20 doses of nivolumab, and after nivolumab, the patient developed this very severe, not so severe Raynaud's, but the Raynaud later on got better when the patient got pentoxifilin. And of course, I skipped those, and these are the recommendations how to manage the checkpoint inhibitor caused autoimmunity, but we're gonna learn about it later. But let's show our own study. Our own study consists of 207 cases of checkpoint inhibitor treated cases. You can see what kind of cancer. We used either nivolumab or pembrolizumab. It's 270. Two-thirds of the patients received nivolumab and one-third received pembrolizumab. And most of the cases in the pembrolizumab was actually lung cancer and urinary bladder cancer. Those with the nivolumab was renal cancer, lung cancer, and pharyngeal cancer. And these are the immune-related adverse events which occurred in 66 cases. So one-third of the patients who was treated with ICIs developed some grade of autoimmunity. And as you see, different organs were involved in different percentages. The paper is now accepted in the Frontiers of Oncology, so you can read it. So basically, every single ICI-treated patients might have autoimmunity, so this requires, again, a very close relationship. So when you go home from this congress, find an oncologist and build a bridge, and when they treat these patients, some of them will get to your department. Because if the ICI adverse events are very mild, even the oncologist can treat it. But if it's more severe, they might ask for your help to give biologics or methotrexate or whatsoever, but we'll hear more about this later. Then we have two more chapters, and one is, which I will finish quite shortly, is the bone effects of hormone deprivations. No matter if it's a breast cancer or a prostate cancer, in breast cancer you use aromatase inhibitors. In prostate cancer you use anti-androgenic drugs. So because you are blocking the estrogen and you are blocking the androgen, definitely these patients, all of them, will develop osteoporosis. I don't know how is it in Romania. In Hungary, the recommendation is that every patient who is receiving deprivation should have DEXA, even if they are younger. This is the mechanism on the figure, how osteoclasts are activated. And of course, this is basically a hormone deprivation situation. And this is an old study when they used tamoxifen, anastrozole, with or without zoledronic acid. And the top two curves show you what happens when you have zoledronic acid. There is basically no bone loss. And if you don't use zoledronic acid, then in about 2-3 years, the patient will lose some of their bone. There are also studies in denosumab and recently also teriparatide. But the number one is zoledronic acid. The number two is denosumab. These are the two ones where you have strong evidence that they can actually prevent. And this is very difficult because if the patient didn't have osteoporosis, how can you prescribe these drugs? It's not possible. So actually you have to prevent the loss. So you have to prevent exactly at the same time. When the oncologist starts giving aromatase inhibitors, you have to check, and then you should do a prevention, which you can't. So what you actually do, you just keep doing the DEXA, and once the DEXA goes beyond 2.5, then you give the drug, which is actually not the right approach. So there is no reimbursement for prevention with bisphosphonates. Actually, oncologists can use bisphosphonates for free, but that's a different drug. So I don't know how to solve this problem, but this is also a reimbursement issue. And now that bisphosphonates are so cheap, there might be a possibility that the patient buys and gets this bisphosphonate, without that. And this is a suggested management algorithm. So if you initiate aromatase inhibitor, then you do the DEXA. If the DEXA is still normal, you just give calcium and vitamin D supplementation. But if you have osteopenia already, then you have to look for additional risk factors. And if there are additional risk factors, you have to start bisphosphonates. And if there are fractures already, you can give denosumab as well. And finally, my last 2 minutes before the discussion, even musculoskeletal malignancies can occur. Of course, they are very rare and usually developed by oncologists. And until you are watching these pictures, let me show you just 2 very short cases. I had a patient who was a 16-year-old girl and no problem, just a hip pain. And by the time she had the hip pain, she already had osteosarcoma all over her body, and she died in about 3 months. So, of course, this is an extreme case, and not every young person with a hip pain would have cancer. But that happens, and that's why I wanted to tell you. And second case would be a very rare case of synovial sarcoma, that a patient had a lump on the cervical spine next to it. You can see on the top, it was a big lump. First they thought it's something like a lymph node or something, but then they took it out, and the calponin positivity, the beta-catenin positivity, and then the fish actually proved that it was like a chromosomal rearrangement leading to synovial sarcoma. Synovial sarcoma can be also treated by checkpoint inhibitors. So this patient responded well at the beginning after the operation. Unfortunately, after 4 years, the patient died. But then it means also that a rheumatologist, it depends on where the patient goes first, because if it's a lump, the patient might go to the oncologist first, and then, you know, it's already in hand. But if it's the first symptom is a pain, like a hip pain or a cervical spine pain, and you have to do the physical examination, these patients might just come to you first, and sometimes you can discover these malignancies, and then you have to treat the patients together. So going back and just summarize what I was saying, there are at least 8 pillars of oncorheumatology. Some of them will be discussed later. So the rheumatologist, oncologist, radiologist, and all kinds of disciplines should work together, because there is a possibility that you treat the arthritis, the patient will develop cancer, or the oncologist treat the cancer. They give some drugs like aromatase inhibitors or immune checkpoint inhibitors, which will develop a disease, which then the rheumatologist will have to do. So of course, I was lucky that I had a sister who's an oncologist, so we can do it within the family. But if you go back, you just find an oncologist and build up a relationship, because these things will quite often occur, and that helps if you have somebody who will help you. And this was the review we published some years ago. Thank you very much.